Today I invite our TNMC observer is Dr. Tirupati sir. And I request Dr. Selvamuthu Kumaran sir to moderate the session, take over and moderate the session. Before that, we will have an introduction of Dr. Selvamuthu Kumaran sir. Dr. Selvamuthu Kumaran did his MCH neurosurgery from Madras Medical College, completed in 2002. Has specialization in micro and endoscopic neurosurgery. Current position, senior consultant and head of the neurosurgery department, Meenakshi Mission Hospital and Research Center, Madurai. He is expert in all aspects of neurological surgery for complete brain management, spinal cord and peripheral nerve disease and disorders. And they are having the DPNP program, which is very well organized, and every year they are training more PGs. I welcome Dr. Selvamuthu Kumaran to take over the session and moderate the session. Thank you.
Good evening, everybody. I think we have around 166 participants. It's very good to see so many participants. So neurosurgery is not just brain and spine. So other aspects are also there, especially peripheral nerve and carotid artery disease. Usually for these carotid artery disease, during our PG period, we don't have much exposure. But I think neurosurgeons should know these aspects also, carotid artery. So only I thought we will have carotid artery as a carotid artery stenosis as the CME for today. Because other CMEs were more of an brain and spine. So to take away from that, I thought we had this, we can have this topic, and Dr. Rajesh Babu immediately accepted this, and thank you for him. So today, as Dr. Rajesh Babu told, we have two speakers. One is Professor A.G. Santhana Krishnan. He is a neurosurgeon. He's a HOD. He is HOD Department of Neurosurgery at Stenting Medical College, and also he's a senior consultant neurosurgeon at the hospital he owns, Bharathi Hospital in Madurai. And the second speaker is Dr. Gowtham Kunja. He did his DRNB at the Meenakshi Mission Hospital, and he's a new kid to the neuroendovascular department. And now he is a neuroendovascular surgeon at Meenakshi Mission Hospital. So first, we will have a topic from Dr. Gowtham Kunja. He is going to speak on endovascular intervention in carotid and vertebral artery stenosis. Over to Dr. Gowtham Kunja.
Can I start? Can I start?
Yes, Gowtham. Yes, Gowtham. Yes, Gowtham.
Is it visible, sir?
Yes, yes, visible.
Okay.
Yes,
now?
screen. Yes, good. Yes, nice.
Okay. A very good evening, everyone. I'm Dr. Gowtham. I just recently finished my DRNB neurosurgery from Meenakshi, and then I did my fellowship in endovascular for 1 year. And now recently, a few months back, I joined back in Meenakshi as a consultant. Today's my topic is going to be about neuroendovascular intervention in carotid and vertebral artery stenosis. So coming to the, what is a stenosis? Why should we treat stenosis? Because whatever the cause may be, it could be because of atherosclerosis or a dissection or spasm, whatever it is. The main problem is progressive narrowing of the vessels. So that progressive narrowing ultimately leads to the flow limiting stenosis, which have mainly two effects. One is flow turbulence, and there is another one is the decreased flow. Flow turbulence will cause thrombogenicity, where blood becomes thrombogenic, and this will keep on causing multiple distal embolizations frequently. Or in some other cases, there will be complete local occlusion at the point of stenosis that can present as an acute stroke. On the other hand, there is because of the decreased flow, there is hemodynamic insufficiency. Because of that, patient can develop clinically, patient can present as transient ischemic attacks, and radiologically, it can manifest as watershed infarcts. Now, coming to carotid stenosis. This is stenosis means narrowing or blockade of internal carotid artery, usually at CCA bifurcation region. And stenosis is the radiological term for narrowing irrespective of the disease or pathology, whether it is atherosclerotic or a dissection or spasm, or could be anything else like tumor invasion or something. So for stenosis, we have mainly two modalities of treatment. One is surgical carotid endarterectomy. The second one is endovascular carotid stenting. And today my topic is going to be on endovascular. So for carotid artery stenting, usually we do in mostly two scenarios, either in elective or emergencies. In electives, usually when there is a significant stenosis, patient presenting with the TIS or minor stroke, or when the patient comes with acute stroke and comes for endovascular mechanical thrombectomy, and intraoperatively we found, intraoperatively or preoperative imaging, we see proximal carotid stenosis. For diagnosis, usually there are two imaging modalities for diagnosing and quantifying this carotid stenosis. One is carotid Doppler. Usually we see a very smooth flow in carotids, and the peak flow is usually around 50 to 60. This is how it appears in a normal vessel. And when there is stenosis, there will be a lot of turbulence at the point of stenosis, and the peak velocity will reach very high, more than 120, sometimes 200, 250 also. So the added advantage with Doppler ultrasound is that we can actually see the vessel wall in this. So we know the actual dimension that it is supposed to be anatomically and how much it is at the same level. So we'll have an accurate estimation of the exact stenosis. But again, this is very highly subjective. There is a lot of interoperator variability, and even now there are recent guidelines that for diagnosing a patient for carotid stenosis based on carotid Doppler, it should be performed by two independent operators at two different time periods. This is another modality, digital subtraction angiography, where we inject a dye and image the vessels. But one disadvantage in this is we can't see the vessel wall. We only see the lumen. So we don't know what is the exact dimension here. But on the brighter side, we have more of an objective kind of measurement in DSA. So based on these two investigations, there are two main ways by which we calculate the carotid stenosis. Both are used in two major landmark studies. One is ECST, which used ultrasound Doppler, where it measures the dimension at the same level and also the diameter of the actual vessel wall. And the NASET trial, which actually measures the diameter, which is based on DSA. So the next maximum possible normal diameter is usually considered as denominator. So because of this, when there is a 50% stenosis in Doppler, it usually means there is 30% stenosis in DSA. So this is the kind of table that they have given. So coming to significant symptomatic carotid stenosis. So this is the first time these two landmark studies, NASET and ECST, actually established that treatment is necessary to treat carotid stenosis to prevent morbidities and mortality. So there is a very strong recommendation for symptomatic carotid stenosis when it is more than 70%. And even in moderate cases, the moderate stenosis of 50 to 69%, and the patient is symptomatic, it is a weak recommendation, but definitely it is going to be helpful to treat the patients. And ideally, this should be done in less than 2 weeks. So these are the main recommendations by NASET and ECST trials. Coming to asymptomatic patients, there are two trials, ACST 1 and 2. So in these RCTs, they mainly measured, they mainly estimated the asymptomatic carotid stenosis. So they considered stenosis more than 60%. And in these patients, even if asymptomatic, there is a strong indication for intervention, especially carotid endarterectomy. So these are the two studies, SPACES and EVA3S, that actually compared stenting versus endarterectomy in a randomized controlled manner. So in these two, after the final conclusion of these two is, in general, for symptomatic carotid stenosis, carotid endarterectomy is more preferable rather than stenting. But in a specific set of patients, that is especially when the age is less than 70 years old and when there are multiple surgical comorbidities, stenting may be considered as an alternative. During around the same period of time, there is another landmark trial, that is CREST, which actually tried to evaluate the factors favoring that are favorable in the stenting and that are favorable in the endarterectomy. So carotid artery stenting is superior in mainly three aspects: to decrease the incidence of perioperative MI, to decrease the incidence of major non-ipsilateral stroke, and especially there is a huge difference in the incidence of cranial nerve palsies because obviously there is a high risk of cranial nerve palsy in the surgical endarterectomy. So based on these three and rest of the main main surgical contraindications, high risk for surgery cases. There is one study called Sapphire study that has actually randomized a total of 2,000 patients, which has got high surgical risk factors. So they did a endarterectomy. And as you can see, the major adverse events in these cases is almost equivalent to the carotid endarterectomy group. It is actually this Sapphire study that was actually submitted for approval for FDA for carotid stenting, and it got approval. So after all these studies, finally, we have one vague picture like carotid artery stenting is preferred over endarterectomy when the age is less than 70, patient is symptomatic and more than 70% stenosis is present. If there is a high riding carotid bifurcation where surgical exposure is going to be difficult, or surgically high risk patients like recent MI, which has got a high, because the carotid endarterectomy has got a high incidence of perioperative MI. So recent MI, unstable angina, severe pulmonary disease, when these kind of situation is there, stenting is preferred. Prior neck irradiation, where surgical exposure of neck is going to be very risky. Non-functional contralateral vocal cord because of the incidence of cranial nerve palsy. Tracheostomy dependent patients, contralateral carotid occlusion, and when there is a recurrence of stenosis after endarterectomy. In all these scenarios, carotid artery stenosis is preferred over endarterectomy. Stenosis, the carotid artery stenting is better avoided when the age is more than 70 years and symptomatic and more than 70% stenosis, especially asymptomatic stenosis. No degree of stenosis in asymptomatic stenosis, CA is advisable. Calcific and eccentric plaques, because of their mechanical properties, usually when we deploy the stent, the expansion of stent is going to be very limited. And when there is extreme arch anatomy with very difficult endovascular axis, or femoral or radial approaches are unavailable because of peripheral vascular disease, or of course, iodine contrast allergy. Coming to the technique, usually we use femoral artery or radial artery, but in our center, we are routinely using femoral artery approach. General anesthesia can be used, but preferred is conscious sedation, because we'll have a clinical monitoring of the patient. If there is any thrombosis in the stent or distal embolization, we'll have an immediate picture of if any patient is going to develop any stroke. So this should be done in angio suite with neuro capabilities, and usually we preload the patients with dual antiplatelets for 5 days in case of elective cases, and just intraoperatively or 1 or 2 hours before the surgery in case of emergencies. So in femoral approach, we usually keep a long sheet from right femoral artery into the common carotid artery. So once there is we have a distal access catheter in position, then we will pass a small narrow 0.14 diameter wire over which there is already the distal protection is mounted. Then we deploy the distal protection. After that, we'll send the shuttle sheet, and then we deploy the stent. Once we deploy the stent, we'll collapse the distal protection device, take out the wire, and remove the distal access catheter. So this is the overview of the exact procedure that we do for carotid artery stenting. Just a few cases about this. This is a 63-year male, known case of CA thyroid post-neck radiation with recurrent TAs for the past 2 months. Doppler showed significant stenosis more on the right side. So this is the case. As you can see, this is a very bad carotid artery where you can, if you consider this is the vessel wall, you can see this is the vessel wall, and this is the stenosis. Sorry. This is the stenosis. You can see there is a big atherosclerotic plaques. There is flaps with a pseudoaneurysm formation. And here you can see an ulcerated plaque, which is highly thrombogenic, and there are multiple pseudoaneurysm sacs. So this is a very high risk case for even for surgery because of post-neck radiation. So this patient was selected for endovascular stenting. So once we take into the cath lab under general anesthesia. Sorry, this is in sedation, conscious sedation. So first we take the guide catheter into the common carotid artery, then we send the wire, and you can see this is the distal protection device which is mounted on the wire. Here it is seen very clearly. So as you can see, once we pass beyond the stenotic segment, we'll deploy the distal protection device, which acts as which is kind of a basket that we keep in position to hold the debris, just in case. Okay. So then once the distal protection device is in position, then we'll pass the stent. After that, we'll start deploying the stent. So usually in this step, there is a lot of manipulation of the vessel. So this is the step where there is a high incidence of thrombus migration distally. That's why we use this distal protection device. After the stent deployed, you can see that there is the wall has become more or less even, and there is good flow. And if you see closely and carefully, you can see this is the ring, and this is the basket, which is not visible, which is not radio opaque. And these small filling defects are actually the debris that are formed while deploying the stent. And this basket has nicely caught those debris. And after that, we'll just internalize the distal protection device and then slowly pull it back. So this step is also critical in the way if the basket gets struck into the struts of the stent might get displaced, or it can get fractured, injuring the vessel. So after removing the basket, we can see the debris that it has collected. And this is the post-stenting distal flow. This is the most important step in any neuro intervention, to check the distal flow after we finish the procedure. So this is another case, 69-year male, non-diabetic and hypertensive, recurrent TIA for 3 months, Doppler showing complete occlusion. So we did DSA. DSA is showing very irregular stenosis with kind of blood dribbling through the crevices of this stenotic, the diseased wall. When you see closely, there are small opacities here, which is calcium. So this is a very highly calcific plaque. So this is ideally, this is not a candidate for endovascular thrombectomy. So endovascular stenting. So we did endarterectomy, surgical endarterectomy for this patient. So that is elective. Coming to emergencies, this is tandem occlusion, where there is carotid stenosis present with an acute ischemic stroke. So far, this is usually a rare condition, and the evidence available is very limited. And recently, in 2021, there is one nice publication in American Heart Association, done by American Heart Association. Here, they have seen modified Rankin scale at 3 months follow-up in anterior circulation with tandem lesions. As you can see, the MRS is very poor in almost more than 50% of the patients. So they've divided into 2 groups. One is acute extracranial ICA treatment, that is stenting or balloonplasty, or without any treatment, only mechanical thrombectomy for the intracranial occlusion. You can see there is a huge difference in the MRS at 3 months. The patients who underwent the treatment for carotid stenosis at the same sitting of the mechanical thrombectomy has very good result compared to no treatment patients. And after this, there is one more dilemma, whether to treat the proximal stenosis first and then go for mechanical thrombectomy distally, or first to do distal thrombectomy and then come for the proximal stenosis. So this is the comparison between extracranial first, intracranial first. So in intracranial first approach, there is a slightly better outcome in the modified Rankin scale, but this is not statistically significant. They appears to be almost same. This is another case. This is a case of 76-year male with acute stroke, 8 hours since onset, left ICA and MCA, tandem occlusion is there. As you can see, this is the ECA filling, and this is the ICA that is completely absent. And there is a small, very minor streak of contrast flowing through this. So after some wire manipulation and keeping the microcatheter inside, there is some opening of this stenotic segment, and there is some distal contrast filling. Then there is deployed the stent, and then went into distal for mechanical thrombectomy. This is another case, 67-year female, acute stroke, 3 hours onset, left ICA and MCA, tandem occlusion. So DSA was done, which appears to be a tandem occlusion. This is, we face this many times, because when we inject in the common carotid artery, the contrast flow is not, because of the stasis of blood, there is no contrast flow that appears like a tandem occlusion. Actually, when we went in with the aspiration catheter and injected inside, the vessel is actually clear, and the occlusion is actually at the level of distal ICA. So after mechanical, thrombus aspiration, the distal flow is good. So this is very important. When we want to treat carotid stenosis in a case of acute stroke for mechanical thrombectomy, differentiating between true occlusion and pseudo occlusion. True occlusion, appearance-wise, when you can see the plaques and a kind of flame kind of appearance. But in pseudo occlusion, when you see, this is pseudo occlusion because of stasis. There is no occlusion in the ICA, but because of the stasis and the supine position of the patient, the high density contrast has actually settled down here. You can see the smooth line. So this is, this is not a rule, but this is usually how it appears. So recent advances. I mean, all the past Sapphire study, whatever study has happened, they usually take many years, sometimes even 10 years or 15 years for the study to get published and everything. But advances happens every few months. This was the initial stent, that is carotid wall stent. As you can see, this is just a metal mesh. Because of the less percentage of metal, this is usually less thrombogenic. But while deploying, there is a high risk of the thrombus that forms outside the stent to migrate inside and go and cause distal embolization. So for this, then a few companies like Bard, they developed a covered stent. As you can see, it has a metal skeleton which has a cover. So this has completely stopped the incidence of thromboembolism intraoperatively, but this has a very, very high risk of stent thrombosis because of all the foreign material that is present. So recently there is another stent that is called C-Guard, which is kind of hybrid between these two stents, whereas there is an inner skeleton to give mechanical strength, and there is a outer thin meshwork to prevent embolization. So this is the kind of advances that is happening in months. And if you see the distal protection devices, the first distal protection device ever introduced was a balloon, just to keep the balloon distally, and just as long as the balloon is inflated, the clots will get a clot there. Once the balloon is deflated, they will get embolized. So then a few devices that came, like this is called Spider. So this is very bulky, and this needs the requirement for catheters is very large, and the maneuverability is very less. Then came filter easy wires. That is actually this basket is actually rolled around the micro wire so that it is easily maneuverable. This is about carotid stenosis, and coming to vertebral stenosis. Actually, the incidence of vertebral stenosis is very, very less. There is only one well-designed study trial that is published in 2017 for vertebral artery stenosis. So in this study also, out of a total of almost 200 patients, only almost 35 patients, that is around 17 or 18% of the patients had intracranial vertebral artery stenosis. Most of the patients had extracranial vertebral artery stenosis. So in this small group and this small low quality evidence, what we can say is, if you see the cumulative probability of stroke over a period of 7 years, this is a good follow-up over a period of 7 years, is just 0.05 in the cases of stenting, and the medical group, it keeps on increasing. And fatal or non-fatal stroke or TIA, if you see, again, there is a difference between medical and stenting group over a period of 7 years. This is just a small case of vertebral artery stenosis, a 49-year female, recurrent posterior circulation stroke for the past 6 months, right before complete occlusion and left before critical stenosis. You can see this right side vertebral is completely occluded. There is no flow, and in left side vertebral, there is a critical stenosis, and there is a thrombus floating in the vertebrobasilar junction. So initially we deployed a stent in this patient, but the stenosis was very narrow, and the stent was unable to open completely. So then we passed a balloon into the stenotic segment and then did a balloonplasty. So after balloonplasty, the stent is widely open, and this is the distal flow after the procedure. So to conclude, endovascular interventions for carotid vertebral stenosis is established to be more efficient and safer in a selected set of patients, not in all patients. Most of the patients, even we prefer to do carotid endarterectomy. Very selected set of patients, this is a good alternative to endarterectomy. And extensive research is going on in this field. New devices, as I said, are being introduced every few months. On the other hand, well-designed and quality control trials are taking years to decades to be conducted and published. So this is a kind of two-edged sword. As more and more recent advances and new devices are coming up virtually, to see it is getting safer and safer. But actual numbers, whether they show up or not, that we are not sure. Thank you all for your patience and attention.
Thank you, Dr. Gowtham. I think we have the questions at the end of both the lectures. Dr. Santhana Krishnan joined. Sir.
So it was a nice discussion. And so what we will have is, at the end of the two topics, we will have the discussion and doubts will be cleared. That is the thing. And at this juncture, I welcome our President-elect Dr. Suresh Jayavalan sir for this CME program. And Selva, you can carry on and invite the next speaker.
Thank you. Thank you.
Dr. AGK. Santhana Krishnan is there?
I'm here.
Yes. Yes, Dr. Santhana Krishnan. Time evalu sir, Harish Babu sir, time evalu around.
Sir, start பண்ணலாமா sir? So question flash பண்ணட்டுமா sir?
Hello, Rajesh Babu sir. Okay.
First question.
Hello, everybody.
Yes, sir. Yes, sir.
In which of the following patient carotid endarterectomy is preferred over carotid stenting? A. Presence of dissecting pseudoaneurysm. B. Calcified eccentric plaque. C. Carotid stenosis after neck irradiation. D. Contralateral lower cranial nerve palsy. Question 1. Okay, people can start asking doubts about the first speaker's talk.
So when you intervene, Dr. Gowtham, the patient has a stroke today and he has stenosis of 80%. So when you want to intervene, after 1 week or 2 weeks, what is the ideal time to intervene? Dr. Gowtham is there?
Yes, sir.
Yes. When you
So
want to intervene?
The recent guideline says we have to intervene in less than 2 weeks, sir.
Less than 2 weeks. Why you said less than 2 months? What is the criteria? You said if you are not intervening before 2 months, you told no.
No,
before 2 months, sir, 2 weeks. 2 weeks. So beyond 2 weeks, it's not helpful. It's not going to help.
No, treatment effect is not as comparable to before 2 weeks.
Okay. So you showed some new devices.
Yes, sir.
So any difference between the older device and new? Any RCTs are there between the older devices and newer devices?
No, sir.
Any comparison studies are there?
No. Very limited literature support for each device. Obviously, because of the financial problems. I mean, and the thing is, it's more of a personal experience kind of thing, sir, because it is difficult to randomize between one company and another company and do a good randomized control trial or something. So it is more operator experience.
What are the RCTs you told? RCTs
yes,
between CEA and the stenosis.
Yes, sir.
When was it done? Before 2010 or most of them between 2010 to 20?
Yes. Well, the
Sapphire study are very old only.
Yeah. Sapphire study, they used one device from Abbott company. So for one trial, they are using one company device to maintain the uniformity. But there is so far there is no proper evidence for to compare between different devices.
Dr. Gowtham?
Yes, sir.
Hi, this is Dr. Venkatesh. Nice presentation.
Thank you.
Young, energetic endovascular surgeon. My question to you, if the patient presented with severe carotid stenosis along with chronic IC occlusion, will you go for endovascular intervention or?
Sorry, sir. Can you come back again?
If the patient presented with severe carotid stenosis with chronic IC occlusion also, long segment IC occlusion, what will be the line of management? Will you go for endovascular or?
Long segment IC occlusion means, do you mean thrombosis, sir?
Yeah. Like, you got my question?
No, when there is a significant stenosis of the carotid bifurcation.
Significant common carotid artery stenosis, that bifurcation stenosis, along with chronic IC occlusion, not acute, chronic IC, complete long segment occlusion. So what will be the line of management?
No, if it is a chronic, you mean complete occlusion of ICA?
Yes.
Okay, sir. So if there is a complete occlusion of ICA and the patient is having minimal symptoms or no symptoms, that itself means that there is good collateral network developed from either contralateral hemisphere or posterior circulation. So we'll just evaluate with DSA if there is how good collaterals are holding. Or if anything, any other vascular pathology in the contralateral carotid or posterior circulation major vessels that can preclude in future can cause some occlusion and go for a complete cerebral hypoxia. So for that, we'll evaluate the collaterals, sir. I think complete occlusion, there is no role endovascularly.
So you will not go for endovascular, right?
No. Complete occlusion, no role for endovascular. At least we should have a small gap, at least to pass the wire. Without that, there is no role of endovascular. Okay.
My second question. One case you had discussed that the post-radiation with multiple vessel wall abnormality. So is it ideal to go for that endovascular thing? Because you're doing so much of manipulation that itself causes there is a vessel wall leakage and the thrombus, emboli. So better go for a primary occlusion with the bypass. That will be the ideal, in my point of view. So what about your?
No, as the evidence already suggests, when the patient of previous neck irradiation who are not a good candidates for surgical neck exploration, then I think endovascular is preferred for this patient. Especially had a previous neck irradiation. He has a carcinoma of thyroid, and I think that for that particular patient, I think endovascular is the preferred treatment. Even I think the previous evidence also supports the same.
Okay, Gowtham. Thank you.
Dr. Tirupati?
Thank you, sir.
You want to ask some question?
Kindly unmute and
Dr. Tirupati?
Oh, yes, I'm sorry. Hello?
Yes, sir. Yes, sir. You want to ask some question? You have raised your hand.
It's a good presentation, Dr. Gowtham.
Thank you, sir.
Thanks. First, you told about the collaterals. Yes, that's very, I think, for any procedure, whatever, whether you go for endarterectomy or this, the status of the collaterals is a key point, definitely. How do we assess the collaterals pre-intervention? That's very important. That's a key. Because we have seen many patients with total occlusion with no symptoms at all, because they have collaterals, actually. So how, I think any vascular inflict, because it's compensated state, how assess the collaterals? First one. Second question is, yes, every practitioners may not access to the DSA. So everybody goes for a CT angiogram. CT angiogram, how can you decide about anything that's a possibility scope of decision making between DSA or, endarterectomy or endovascular? Because this is more available, methodology available throughout.
Yes. So regarding first question about collaterals. Usually there are two ways, sir. One is technically, scientifically correct way to do balloon occlusion. We keep a balloon in the vessel under evaluation. We keep a balloon and inflate it. Then we do a contralateral injection. For that, usually we need 2 femoral punctures and go in. So once we inflate the balloon and occlude the vessel under evaluation, after we inject, the main emphasis is on the venous phase, early venous phase. So what is the, I mean, because DSA is a dynamic study, we will have the flow patterns in both the hemispheres. So the time difference between 2 hemispheres, when it is less than 4 seconds, technically that means there is good collaterals. And when the difference between the early venous phase between the 2 hemispheres is more than 4 seconds, it means the collateral supply is inadequate. And instead of using a balloon, routinely we use external compression. Other than that, the evaluation part is the same. We do injection and we see how much is the difference between the venous phase between both hemispheres, and we'll decide whether it is adequate or not. Okay, sir. And again, sir?
No, okay. Answer.
About the CT angiogram. It's the same thing as I told. So CT angiogram is widely available. So to get an anatomical picture of the carotid stenosis, presence of the characteristics of plaque, if at all any calcium is there. So these things are better identified with CT angiogram, and it is available widely. But the only difference with the DSA from CT angiogram is the dynamics of the study. In DSA, we have flow dynamics, and most of the times, even we got few cases where CT angiogram showed complete occlusion, absolutely no flow of contrast. But in CT angiogram, there is in DSA there is a small streak. The level of concentration, the concentration of contrast that is maintained in blood for a CT angiogram is much lesser when compared to DSA. So DSA has got more clarity about these kind of things.
In that follow.
Yes.
So can I continue one more?
Yes, sir. Yes, Dr. Tirupati.
Okay. In that event, yes.
Yes, sir.
When you decide, okay, CT angio is done, or you go for a DSA to assess the patient. At one go, you go for a diagnostic and therapeutic, or diagnostic once and then decide about the endarterectomy or you decide, or you keep ready for single shot.
No, sir. First we will do diagnostic.
Diagnostic. Okay.
Dr. Gowtham is a nice
Now we will
percentage.
go for the second question, sir. 1 minute, sir.
Okay.
Yes. Dr. Suresh?
Yeah, okay. Let him finish.
Okay.
Question number 2. Which of the following statements is true about carotid stenting? A, preferred for an asymptomatic stenosis of 80%. B, always performed under general anesthesia. C, more beneficiaries for age above 70 years than less than 70 years. D, performed within first 2 weeks after a stroke, gives better results. You can start answering, and the first response will be awarded. Whether Dr. Santhana Krishnan is ready? Santhana Krishnan, sir?
Dr. Suresh, I think you can ask Suresh Jayabalan, you can ask.
Yes, Dr. Suresh
Okay.
Jayabalan, sir.
So here it is coming. Okay, just Dr. Gowtham, nice presentation. I just wanted to know what is the percentage of bleed after your carotid stenting?
Sorry, sir. What is the percentage of
bleed? Post-surgical bleed. Bleed, yeah.
I mean, a bleed either in the neck or in the intracranial vessels.
No, intracranial I am asking.
Intracranial. Oh,
Yes.
when it is acute stroke and there is a well-developed core, the risk of bleeding is very high, sir. But otherwise, in an elective case of stenting, I don't think there is any risk of intracranial bleed because of the stent.
No, you just mentioned that you would prefer to do within 2 weeks of stroke.
Yes, sir.
So, what is your experience of the bleed after stenting? We know about the carotid endarterectomy, and the main problem with the stenting we encounter is a post-surgical bleed. I'm just asking about your experience.
Yes, sir. Sir, I personally doesn't have much of experience about this. That is just what the evidence says. During my training period, we used to do stenting at the same sitting of mechanical thrombectomy when the patient comes with a major stroke. That's what we used to do, and we have never seen bleed beyond the core. Beyond the core, that shows up in the perfusion scans. So, and otherwise, we have done stenting mostly in cases of TIS and long-standing minor recurrent strokes, sir. So, less than 2 weeks of a major stroke, I personally don't have experience, sir. Only evidence.
Thank you.
Thank you, sir.
No, is DSA is necessary in all cases of carotid artery stenosis? Just Doppler, can we go and do endarterectomy, or patient is having a recurrent TIA, Doppler shows an 80% block in Doppler.
Yes, sir.
You go for DSA, or what you do?
Recently, there are few studies that says that if we are going to take a decision based on Doppler, it should be performed by 2 independent operators at 2 different points of time, and both should have got the same percentage of stenosis. Then it is reliable. Otherwise, if there is any gross mismatch between the two observations, better to go for a DSA because it is more objective.
Yes, Dr. Tirupati. Dr. Tirupati, kelunga.
Nowadays,
Okay.
every other day, the cardiologist is doing a DSA for carotid, and they also do a carotid angiogram. If this is a catch area where there's always a possibility of having a carotid stenosis catching up there. So, what will be the strategy with the cardiologist at that point?
I don't know how I can answer that question, sir.
That is very important because that becomes, which we as neurosurgeons do specific cases, but they do, and as a package, every cardiologist does a carotid angio also,
Yes,
and they
sir.
do more cases also. So, what about the further? See, this is how what I call we can have interdisciplinary approach, so that we can have a good protocols in managing when there is coexisting on the problems.
Sir, I think
any strategies followed there?
Sir, I don't know about the strategy, but personally, I think all the carotid stenosis cases are initially seen by neurologists.
Okay. I'm not that way. What I'm saying,
I mean, having a good rapport with the neurologist is the thing that.
I wish you should have a rapport with cardiologist also.
Yes, sir. So if we are in good relation with the neurologist, I think they will prefer us because we are more experienced in handling neuro issues.
I'm serious about it because Dr. Surgeon may agree with me. When we are Japan, they do a CT angio for every person after 55 years.
Yes.
They pick up incidental aneurysm, clip out, do.
Yes, sir.
It's a method of extending the method of primary or secondary prevention also. So that is way forward. Is one thing I want to put forward here. Second thing is taking a cue from the previous MCQs. Do we adhere to the age of the patient first? Because that is an old term. Nowadays, I think the vascular age is more important than the person's age because the trends have changed. We have seen 40 years having a very vascular issues, and 70s, 80s are more fit. Still, the age criteria as a physical, numerical age criteria holds or vascular age criteria holds?
Sir, I think the vascular age criteria, as you said, there is a huge difference between Western population and Indian population, sir. Whatever their studies, they mean by the age of 80 years. I think the similar kind of picture we see here in 50 years. That is my personal experience. So the literature-wise age criteria, I don't think we can apply to our
ready, Dr. Santhana Krishnan? It is ready? Dr. Santhana Krishnan, is it ready?
The slide is visible, sir.
So my slide is visible.
Yes, slide is visible. Yes, sir.
Yes, sir.
Can I proceed, sir?
Yes, proceed.
Somebody was, I think Gowtham was answering. Let him finish answering and then I'll take over. Hello?
Yes, sir. Sir, yeah, that's what I was just telling about the vessel, the appearance of vessel, the difference between Western population and Indian population. So yeah, that's I just agree with sir, because we can't apply that numerical age criteria that is being published in the Western literature to our Indian population. We have to rely more on the actual anatomical and flow dynamics that we see in our studies.
Thank you.
Okay. Can we move to the next topic? Yes, Dr. Santhana Krishnan, I think you can start now.
Thank you, sir. I'm again sorry for the inordinate delay. I'll straight away go into the topic. Beforehand, I have to appreciate the previous speaker for his wonderful talk. It was eye-opener in many aspects. He had covered most of the areas I thought he covered. So I was I thought I'll omit those areas. Okay, coming back to the topic of carotid endarterectomy, this is one gray area where many physicians clash. Something like so neurosurgeons want to do this patient cases. Same way interventionists have come in now who are doing wonderful job. In fact, they should, I think they will be taking over this from anybody else. Cardiovascular surgeons are also doing, mainly cardiothoracic surgeons and vascular surgeons. But vascular surgical people feel they alone should be doing carotid endarterectomy. And then we have a new generation of interventionists who are actually peripheral vascular interventionists, but then they also want to do it, apart from the neuro interventionists. So in this setting, where do we stand? So we do have a certain practice guidelines, which have been derived from so many studies. But as far as I know of, even in spite of the ACST2 trial, which came, the results were out last August, but in spite of it, I think the last word has not been said yet. Still, there are so many gray areas. We'll have to work into that. Coming to the practice guidelines, as of now, the best medical therapy should be offered to all patients. Until randomized controlled trials demonstrate that best medical therapy is superior to CEA, that is carotid endarterectomy, or CAS, in the prevention of stroke guidelines should remain unchanged. Selection of patients for revascularization depends on comorbidities, life expectancy, and risks and benefits associated with the procedure. Screening for carotid disease can identify patients with significant asymptomatic stenosis who can undergo either CEA or CAS to prevent avoidable stroke. Prophylactic endarterectomy, CEA, can be performed in patients with less than 3% morbidity and mortality risk in asymptomatic patients. Ideally speaking, it would be 1%, but less than 3% is actual. Prophylactic CEA can be performed in patients with less than 3% morbidity and mortality. In 20% occlusion by Doppler ultrasound, or with more than 60% by CT angiography or angiography. This is the ACST2 trial. Only conclusion that has come out in a concrete fashion in this trial is that carotid artery surgery and stenting have comparable long-term effects on fatal or disabling stroke in asymptomatic patients with severe carotid artery stenosis. This is the only solid conclusion that they can come out with. Rest of the recommendations stay there, stay put, it is there. So this trial was done in this fashion. They took a population and studied the outcomes. The outcomes studied were peri-procedural outcomes for less than 30 days. Death, stroke, migraine, procedural outcomes, stroke, stenosis for 35 PICO questions. PICO questions are the problem, intervention, outcome, comparator questions. So this is a randomized controlled trial, and the outcome, the only our solid outcome was that in non-fatal, asymptomatic carotid artery stenosis, the long-term outcomes, both stroke as well as fatal outcomes, remain the same. That was the only solid outcome that they have come out with. So the other practice guidelines of carotid artery stenting can be performed in patients with asymptomatic stenosis more than 60% by angio or 70% by Doppler, or 80% with CTA or MRA. The data on CAS as an alternative to CEA in asymptomatic patients at high risk is unclear. And for patients with symptomatic ipsilateral carotid artery stenosis more than 70%, CEA is recommended if the perioperative morbidity and mortality risk is less than 6%. For the patients with symptomatic ipsilateral CAS between 50 and 69%, CEA is recommended if perioperative morbidity is less than 6% again. The practice guidelines, actually, it was very confusing in many aspects. There are so many studies, so many meta-analysis, but still they have, the last word is not written yet. That is the final conclusion as far as I'm concerned. But then patient preferences are there, and physician preferences are there, and surgeon preferences are there. So, whereas when the degree of stenosis is less than 50%, there is no indication whatsoever for revascularization, either by CAA or by CAS. CAA should be performed within 2 weeks in symptomatic patients, and as early as 48 hours after onset can also be done. CAS should be considered in patients with significant comorbidities, which our previous speaker has dealt in detail. Practice guidelines should favor CEA or CAS and best medical therapy until recent randomized trials demonstrate their superiority over CAA for management of high-grade stenosis in the long run. That is the main point to be taken note of here. The results are out, and it's been only 1 year. And the planning was done in such a fashion that these patients will be followed for the next 15 years. So it will be at least 2036 when the final results of ACST2 are out. So till such time, no final words have been written. So how do we go about doing CEA? That is carotid endarterectomy. So usually after the routine anterior cervical discectomy, those who are familiar with, and then those who have done carotid sheath dissection in their general surgical years, it is easy for them. So once we identify and dissect the carotid sheath, we look for the facial vein, and deep dissection is done after that. Facial vein dissection is very important. So that is the starting point. You'll have to do a circumferential dissection to spare the 12th cranial nerve. Then ligate and divide the main trunk to expose carotid bifurcation. 5,000 units, heparin IV, then develop a plane between the common carotid artery and the internal jugular vein. Carotid sheath dissection may cause jaw or ear pain, it requires additional lidocaine. Place lateral retractor blades between common carotid artery and internal jugular vein. Place medial retractor blades superficially to avoid recurrent laryngeal nerve. Lower retractor can be used with the smooth blade under omohyoid and digastric muscles. You'll have to identify the 12th cranial nerve and position it in such a fashion it does not injure. Then you make use of only the bipolar, don't ever make use of the monopolar. You dissect medially along the common carotid artery up to the superficial temporal artery and the external carotid artery as far as possible. Circumferential dissection of all the vessels has to be done. Distal exposure and vessel occlusion. Here you'll have to be very careful. Dissect lateral to the hypoglossal nerve. Divide artery to superior sternocleidomastoid, small veins and answer. Vessel loops around the common carotid artery, external carotid artery, internal carotid artery has to be taken and rammel it on the CCA. Roll the 1 centimeter into 3 centimeter patty beneath, has to be kept beneath the bifurcation. Shunt if available. We'll have to shunt before opening up the superior thyroid artery. Make use of a small aneurysmal clip to occlude it. For the distal ICA, again a small aneurysm clip distal to the plaque. Atraumatic vascular clamp on CCA at proximal end has to be done. ECA, small aneurysm clip will do. Again, for ascending pharyngeal, if it is in the bifurcation, make use of a small clip. And an arteriotomy has to be done then. Stab incision has to be done through the vessel and the plaque up to the lumen, and then extend it 5 to 10 millimeters. If bleeding, there is bleeding, check clamps, clips, look for ascending pharyngeal artery, which has been missed earlier. Extend the incision toward the internal carotid artery, avoid the bifurcation and extend the incision in ICA as well, beyond the plaque. Avoid spiraling of the incision. It has to be a straight incision from the common carotid artery into the internal carotid artery, away from the bifurcation. You don't end up in the bifurcation region, so that you don't spiral or tear it up. Extend the common carotid artery, arteriotomy proximally. Removal of plaque and closure, close the area of separation. Plaque almost always feathers out distally along the internal carotid artery. Meticulous plaque removal with common carotid artery, sharp transection and eversion of the external carotid artery. You can evert from the external carotid artery, but don't ever do it along the internal carotid artery, because we have seen even vascular surgeons who are very enthusiastic, they used to pull and carotid artery will tear itself off the base of the skull. So that is irreparable, almost like instantaneous hazard. So irrigate with heparinized saline, inspect with magnified vision, 5/0 or 6/0 proline running suture distal to proximal, it should be done. From the distal, that is from the ICA, you'll have to start closing and come towards the common carotid artery. At the ICA, it should be 1 millimeter deep and 1 millimeter apart bites. You'll have to take with the intima. It is intima to intima. If patch graft is needed, Hemoshield is a good option. Rough and smooth surfaces, double armed proline outside in, on patch and inside out at apex of arteriotomy has to be done. And the final closure and reperfusion, check for backflow during closure, and if not adequate, reopen the vessel. If adequate, reapply ICT closure. Closure is complete and reapply the internal carotid artery clip. Check for backflow always. Remove external carotid artery clip first, and then the common carotid artery clamp. Forward flash the external carotid artery for at least 10 seconds. Remove the ICA clip then. The ICA clip should come the last. But then to start with, you'll have to release the ICA clip first and check for backflow. And then only you should clip again and then go for the ECA clip and then the CCA clamp. You'll have to wait for at least 10 seconds. And then remove the ICA clip again at the last. So this is the order in which you'll have to do it. This we'll have to memorize and do it as per that. Examine the patient frequently after re-establishing ICA flow. Additional sutures, if needed, has to be done. So this is how we'll have to rammel up in the common carotid. And then the external and internal carotid. I am showing a PDF here. The video is not playing. I'm sorry. So once you open up the lumen, near the common carotid, it has to be a sharp dissection of the plaque after the plaque is lifted up from the intima. And from the external carotid, you can evert and remove it. This is how you evert and remove from the external carotid. From the internal carotid, again, sharp dissection has to be done. So it has to be intima to intima. The suture has to be intima to intima. It has to be started from the common carotid and, internal carotid, and has to be taken towards the common carotid, or it can come from both the sides, but then from the common carotid, from the internal carotid, it has to be taken towards the common carotid first. And then check for the backflow by releasing the internal carotid artery first. And then again, clip it again. Then go for the external carotid artery and then do. So this is how the suturing is done. The recommendations are the same. It stays, excepting that earlier studies showed the peri-procedural events to be higher in stenting. But the recent ACST study, which was released last year, showed it is not so. It is the same in both. So I think we are gravitating slowly towards the stenting aspect of management of carotid artery stenosis. Though in the long run, the results are, the words are not finalized yet. So what remains to be seen in spite of all these studies is whether correction of hemispheric hypoperfusion with revascularization leads to improved cognitive trajectories. This most often we see in old individuals. So whether this really leads on to cognitive improvement, that is one aspect which has to be studied in the future. And it is being studied as of now in the CREST study. Hope it addresses this point. So as I said repeatedly, the last words are not written at. What is done is not necessarily what ought to be done. We have to take a stand here on an individual basis by individualizing the treatment for the patient based on our past experience and our skill sets. Thank you.
Thank you, Dr. Santhana Krishnan. Any doubts?
You can stop sharing, Doctor.
Someone has raised his hand.
Hello.
Any doubt? Yes.
Sir, my question to Dr. Santhana Krishnan, sir. Hi, sir.
Hi.
Sir, so it was a nice presentation. Sir, I have my two questions, sir. First question, what is the absolute indication for hybrid surgery in case of severe carotid stenosis? My second question is the introp shunting. You have mentioned the introp shunting. Is that mandatory for all the cases, or will you choose in what category you will choose that introp shunting? And one more, are you using IONM for all the cases undergoing carotid endarterectomy?
Here, I should have said in the beginning itself, I'd like to be very frank. My experience with carotid endarterectomy is very limited, and I don't use IONM. I've never used shunts, intraoperative shunts, but then they are preferable, I know. And vascular surgeons always do make use of shunts to start with, but then after 5 years, they once they accumulate enough experience, I have seen people doing away with intraoperative shunts. So whether it is mandatory, I'm not sure. Maybe someone else can throw light on that. I'm not sure about that.
Thank you, sir.
Because
sir. Thank you.
Very limited experience that I have not faced any problems. But then there has to be
I mean, you can put the first question of Santhana Krishnan.
Any other doubts? After this question, we'll continue.
Which of the following is true with regards to ACST2 trial results that disabling stroke or peri-procedure death rates from CEA and CAS are A, the same, B, following CEA is more than CAS, C, following CAS is more than CEA, D, inconclusive results. Yes, we can continue with the discussions.
Yes, somebody has raised his hand. Just introduce yourself. Whoever is asking the question, please introduce yourself.
Hello. Can I discuss?
Hello? Yes, please.
Can I discuss?
Yes, please, sir. Yes, Dr. Tripati.
Continuing the discussion, we have a very limited experience with carotid endarterectomy. But what I would prefer is definitely a intraoperative shunt is mandatory for safety purposes, because we may not be so quick to do that. So it's always better and safe to have a intraoperative shunt, one. Number two is Santhana Krishnan is there. Sorry, you can answer after I discuss. Santhana Krishnan, please.
Thank you, sir. Thank you.
You answer, then we will discuss, please.
Yeah, one point I would like to add here is careful patient selection is important. Supposing if there is a good amount of cross flow from the opposite side, and the opposite side stenosis is not significant, then we can take the risk in not shunting intraoperatively and then go ahead and do the surgery. Usually from occlusion and to clip removal, it takes 25 to 30 minutes. That's the time limit that we usually set in, and we operate at that pace. At that pace, cross circulation is capable of maintaining ipsilateral perfusion, and usually we get away with it. I don't say it is ideal, but as I said earlier, even those vascular surgeons who do routinely these surgeries, in fact, many vascular surgeons who in vascular centers who do this surgery under local anesthesia, especially in the US, I have seen many of their talks, and they do it under local anesthesia, and their operating time from skin to skin, what they say and what their video shows is also 40 minutes at best. That fast is how they are doing it. And there is a study in the Vascular Journal and Stroke and American Heart Journal or whatever, wherever you can find references, so many references are there, wherein they are very clear that carotid endarterectomy is best done by vascular surgeons and not by cardiac surgeons, and to say the least about neurosurgeons. As far as they are concerned, neurosurgeons should not be doing endarterectomy, because our mortality rate and morbidity rates stand somewhere around at 5 to 6%, and they say theirs is at 1%. That's what they say. And as far as this ACST trial is concerned, I am not aware of any neurosurgeon participating in this trial. I'm not sure. I may be wrong. People are allowed to correct me if I'm wrong. But to my knowledge, as far as I went through this, and European Stroke Journal, their presentation also doesn't show any neurosurgeon being involved in it. And that is why they say carotid endarterectomy and carotid stenting, peri-procedural mortality and fatal stroke of disabling stroke rate is equal, 1%. The earlier study probably included our neurosurgical centers also. That is why there is a difference. It was skewed towards the neurosurgeon's opinion, I think. If I am wrong, please do correct.
So now we will go for the last question. Naveen? It is recommended that CEA be done in patients with symptomatic carotid artery stenosis within how dash from the neurological event. 4 weeks, 6 months, 14 days, 1 year.
So Dr. Santhana Krishnan, so how long we can clamp? Any idea how long we can? Because we are putting clamps. So what is the maximum allowed time? Any limit is there? Any idea?
Yes, sir. That's what I said. Like clamp
so said within 20 minutes.
Time
okay, you are doing
30 minutes at best. Anything more than that is disastrous, 100%. Within 30 minutes, you'll have to finish off the vascular work. Okay. That is the best thing to do. And one other additional point that I would like to mention here is like coronary stenting and bypass. Earlier they said that they went for stenting. Now they have again come back for bypass after, because stenting last best was post, 7 years post stenting. Same way the coiling is also going that way, if I am right. So similarly, any stent inside a vascular lumen, it is bound to occlude in the long years to come. As of now, there may be good stents coming in the future, but as of now, where we stand, intravascular prosthesis gets re-occluded 7 years, past 7 years, earlier than carotid endarterectomy. That's my understanding. I may be wrong again.
Okay. Dr. Tirupati, you want to carry on the discussion?
Continuing the discussion.
Gowtham, I think Gowtham can shed some light on this, whatever I said.
Yes, sir. I was just about to give my point about this. Sir, actually, about these two things that were under discussion. One is for intraoperative shunting for endarterectomy. And another point is how long we can clamp the carotid. So I think if we have a DSA beforehand with a compression test, I think we'll have a good idea whether, what is the status of collaterals and how long the patient can withstand carotid clamping for endarterectomy. And if the collateral supply is very, very poor, I think using a intraoperative shunt for endarterectomy would be a safer thing. And that is my opinion.
Can I continue?
Fully agree with this. Yes, I can.
With the limited experience, what I would suggest is definitely intraoperative shunt is a safer option to begin with. And to involve vascular surgeon, definitely I think hardly any neurosurgeons does on his own. Let us be frank on that. So it's a learning curve. It's a new domain. So it's always, we keep vascular surgeon as a primary part. I honestly agree on that point. And always the patch is also used for safer side. These three things has to be to begin, because we are beginners on that. Long way to go on that one. Number two, what I want to ask to Santhana Krishnan, particularly carotid endarterectomy group, is whether a CT angio will do for proceeding with the carotid endarterectomy. Whether CT angio will do, or it's a DSA is mandatory for that. Because this is a very important point. We have to point one thing. And third thing, a common question to both the presenters. Post-operatively, the Doppler, the clinical monitoring is different. How often carotid Doppler is done, or carotid Doppler? I think carotid Doppler is an easy way to assess the patency or the follow-up of the patients. So any protocol or anything, any cues from the carotid Dopplers, post-operative Dopplers, from the both sides. Please, thank you.
Okay, shall I answer first, Gowtham?
Yeah.
As shunt is concerned, as I said earlier, shunt is the ideal thing to do. But without shunt also, we do, and it is okay to do. But then coming to, because as I said earlier, vascular surgeons who initially start doing this endarterectomy with shunt at their later phase, once they gain experience, they do away with shunt. They don't shunt anymore. So they come back to this old route, and they do within half an hour's time. So that is in a way, of course, you'll have to rule out the collaterals, that this and all. Everything has to be ruled out prior to your surgery if you don't want to use shunt. And then coming to this CT angio doesn't give the entire picture. So either it has to be complemented and supplemented with carotid Doppler before surgery, and if possible with DSA, or at least with an MR angio. They are all complementary to each other. They supplement, they give additional information. It is better that we do always a DSA. DSA, to do away with DSA is not right. But when in case, if you don't have DSA, do all the three other tests. And then, of course, as Dr. Gowtham said, occlusion test is again an important aspect of it, which I didn't touch about. I think it is important. Dr. Gowtham.
Third question, Doppler. Post-op follow. Post-op follow with Doppler.
Post-op?
Follow with the Doppler.
Follow. When you do a post-op Doppler, or Doppler?
Post-op Doppler.
Yes, when you do, what time you do? Immediate or after 2 weeks? When do you follow up the patient? How do you follow up the patient?
Best is DSA again.
DSA again.
Post-op DSA is the best thing to do. But then when you have a CT angio, or at least CT angio, rather than Doppler.
Gowtham, which one? Always DSA or go by any Doppler is enough for post-op follow-up?
Immediate post-operatively, usually in doing the procedure itself, we'll have a good idea how much the lumen has dilated. And yeah. And regarding follow-up, in the presence of metal stent, I am not sure how much Doppler ultrasound is going to be useful, or how much of artifact it will generate. I think we should ask a proper diagnostic radiologist for that. I myself doesn't have any personal experience of that. Yes, sir.
But what we found is when they're using a patch, Doppler, post-op period, that's a patient is clinically doing well, doing a Doppler, that always gives outpouchings in the Doppler. They give outpouchings of that. How it is really, it can accept that, because using a patch always produces outpouchings after the flow. Whether that is scary or can just follow it up or anything to be more add on that for a problem.
Yes, sir. That I have observed with our vascular counterpart. Their cases we have observed. I have a vascular surgeon who practices at my facility, and he does carotid endarterectomy frequently. He uses a patch, and we have seen what you are asking for. Usually it is ignored.
You can ignore.
Usually they ignore.
No.
There are leaks. There are leaks.
Not leaks, the outpouchings. I'm not asking.
Yeah, outpouching.
Outpouchings. Because of the pressure, the graft also gives us outpouching.
The graft outpouches. Outpouching is ignored. It takes some time.
Whether the outpouching produces some stasis or not, that is my question.
It will.
Any answer on this? Because I'm not so sure about it. These are the concerns which you have to address. That's why. Thank you.
Sir, any other doubts? Any other questions?
Now we will have the answer session, sir.
Santhana Krishnan, you want to say anything?
No, sir. I don't have anything more to add.
Now we will have the answer session and the.
Go to Dr. Rajesh Babu. I think we had some good discussion.
No, winners announcement we will do, and then.
So thank you, Professor Santhana Krishnan, and thank you, Dr. Gowtham. I think we had some good discussion. I think probably we have to gain more experience in this because more and more neurosurgeons are coming and fighting for everything. And we have to do more and more other procedures also, apart from our routine brain and spine. I think probably peripheral nerve also, I think we should involve more. Okay, what Rajesh Babu?
Now answering and winners announcement.
Yes, Dr. Gowtham and Dr. Santhana Krishnan, you can tell the answers, please.
Yeah.
Yes, Dr. Gowtham.
The following carotid endarterectomy is preferred over carotid stenting. So presence of a dissecting pseudoaneurysm, as the case we have operated and as the evidence is already there, the stenting is preferred. And stenosis after neck irradiation because of the high risk of surgical exploration of neck. In that case, also stenting is preferred. Contralateral lower nerve palsy also, endarterectomy is preferred. No, sorry, stenting. Calcific eccentric plaque. So where the mechanical, the strength of the calcific plaque is so high that it won't allow the stent to open completely, and we may not be able to relieve the stenosis. So in these kind of cases, the preferred is carotid endarterectomy over stenting.
So the answer is B.
For the first question is Trinath. Trinath is available?
Yes, sir. Yes, sir.
You are from?
Chettinad Medical College, sir. Chettinad Medical College, sir.
Congratulations, Trinath.
Okay, sir. Thank you, sir.
Okay. Next question, sir. Next question, Dr.
Next question.
Following statements is true about stenting. In asymptomatic stenosis of more than 80%. Now, the recent ESO, European Stroke Organization guidelines that were published in 2021, there is a recommendation against stenting in cases of asymptomatic stenosis of any degree. And always performed, no. We preferably this stenting needs to be done under conscious sedation when the patient is I mean, we are able to monitor the patient clinically. And it is obviously, literature-wise, it is more beneficial when age is less than 70 years. And performed within the first 2 weeks after stroke usually gives the better result. That is the correct answer. D.
So the winner for this question is Dr. Sivasubramanian. Dr. Sivasubramanian available?
No, sir. Sir is not available, sir.
Dr. Sivasubramanian from where?
Sir, Dr. Sivasubram from Government Rajaji Medical College, Madurai, sir.
Government Rajaji Madurai. Sivasubramanian. Congratulations, Dr. Sivasubramanian. Now the question number 3.
Dr. Santhana Krishnan.
Dr. Santhana Krishnan, sir.
Santhana Krishnan, this is Santhana Krishnan.
Yes, sir.
Yes.
Question number 3. Which of the following is true with regards to ACST2 trial results? The disabling stroke or peri-procedural death rates from CEA and CAS are the same. Following CEA is more than CAS. Following CAS is more than CA, or the results are inconclusive. The answer is they are the same. The earlier trials said CEA is better than CAS, but ACST2 trials with more number of patients enrolled have come out with result as it's the same. Shall I go to the next question?
The winner for the third question is Dr. TamilNadu. Dr. TamilNadu available?
Yes. Good evening.
You are from which institution?
Meenakshi Mission, Madurai, sir.
Oh, congratulations.
Thank you, sir.
Congratulations.
Yes, next question.
Question number 4.
Question number 4 is, it is recommended that CEA endarterectomy, that is, be done in patients with symptomatic carotid artery stenosis within how many days or weeks or months from the neurological event. This is good for, stands good for stenting as well, I think. 4 weeks, 6 months, 14 days, 1 year.
Sir, Rajesh Babu, sir.
The answer is within 2 weeks, that is 14 days. And the winner is once again Dr. TamilNadu.
Where are you, sir? Yeah, thank you. Sir, where are you, sir?
அப்படி கிடையாது அவரு சொல்லிட்டாங்கல பதிலு
சொல்லிட்டாங்கன்னா செகண்ட்ல கொடுங்க ஒரே இது கொடுக்குறீங்க
அப்படி எல்லாம் கிடையாது யார் ஃபர்ஸ்ட் ரெஸ்பான்ஸ் அவங்க தான் ஃபர்ஸ்ட்
சரி ஓகே நீங்க சொன்னா சரிதான்
congratulations TamilNadu
thank you sir
okay sir thank you for a very good discussion can you wind up sir Rajesh Babu sir
yes
what are thanks by
now what are thanks by Kodiswaran.
It was a wonderful CME. Today we had the record of 220 participants. Thanks for Dr. Rajesh Babu for his continuous efforts. He is accumulating more participants every time. And I would like to thank Dr. Sellumathukumaran sir, Gowtham and Dr. Santhana Krishnan for his excellent CME. So thank you for joining us. We'll do next CME next month as per our secretary's guidance. Thank you all.